As a hospital, we were motivated to implement changes to the prostate assessment clinic for a number of reasons. There were obviously patient factors being the primary factors that were driving us, but also benefits to the trust, to the department, and to our individual staff members, specifically around education and widening job roles. There were a number of goals that the hospital was aiming to achieve in implementing the one-stop clinic, particularly around decreasing the time to diagnosis in order to increase the time that was then available for the patients to be treated in before they breached targets, but also the benefits directly to patients in line with the long-term plan, particularly around reducing the number of times they had to attend appointments, to give them a diagnosis at the first appointment where possible, and to ensure that we were offering all of the options that would be appropriate for them for managing their bladder outlet obstruction. Before the department implemented changes to move to the male one-stop lower urinary tract symptoms clinic model, we had a number of issues around supporting the nursing staff performing our prostate assessment clinic. We had a number of issues around the time that patients were waiting and the number of appointments that they were having before a decision for surgical treatment was made. And we were finding increased follow-up of patients that on clinical review was felt to be unnecessary and could have had their pathway shortened to either discharge or treatment. We made a number of changes in transitioning from the prostate assessment clinic to the male one-stop lower urinary tract symptoms clinic. In addition to putting consultant clinicians into the clinic to provide earlier decision making, we moved to a model of sending patient questionnaires in advance, along with information surrounding the tests expected on the day, arriving for immediate flow rate in order to expedite flow through the clinic with bladder scanning after, and then moving into clinical assessment with the availability of transrectal ultrasound for prostate volume assessment before flexible cystoscopy in appropriate patients who were considering surgical management to have direct visualization of their prostate anatomy internally with a view to them being offered the most appropriate clinical option for their lower urinary tract. There were a number of positive impacts that the change in the pathway for the male lower urinary tract symptoms had on patients, and those included patient positive impacts as well as trust positive impacts and positive impacts in the department. In terms of patient positive impacts, we saw a significant reduction in the number of times patients were visiting the hospital, with the inferred benefits around time spent away from work, time spent on travelling and the associated financial implications of those. We also saw that patients were being assessed and diagnosed with treatment plans given in a much more timely fashion, and alongside that, much more likely to have that done at the first appointment, with an over 10-fold increase in those decisions for surgical treatment from the first appointment. On the back of this, the Trust benefited from having decreased patient pathway times, improvements in the RTT that would be associated with that, along with the avoidance of breaches subsequently down the line, particularly alongside the associated transition into the local anaesthetic outpatient surgical management of the bladder outlet. Lastly, from a staff perspective, we saw increased educational benefit for junior doctors in training, as well as expansion of job roles for our nurse specialist colleagues who found it incredibly satisfying to take on these additional roles, perform these additional procedures under the guidance of the consultant colleagues. The changes that we made to the one-stop model significantly improved the situation for both patients coming to our trust and the trust itself, and I therefore feel that they did address all of the challenges that were facing our bladder outlet service at the time. In particular, we saw a reduction in the number of patient appointments that were being spent until diagnosis. With that, we saw a reduction in the time patients were waiting until diagnosis. We, as a department, feel that we more thoroughly assess patients and are now in a position to offer them all of the treatment options for their bladder outlet, and therefore can appropriately inform them of the options that would be best suited to them with what they feel is important to them, whether that is erectile and sexual function or maximising treatment effect relative to their prostate anatomy. And on the back of this, all of the challenges that we were facing were addressed, yes. I think there are improvements to be made in the overall male lower urinary tract symptoms pathway, though I am very happy with how the one-stop assessment clinic is running currently. In particular, I'd like to see improvements in transitioning more patients into the ambulatory local anaesthetic outpatient minimally invasive therapy setting for their bladder outlet obstruction. In my experience, procedures delivered under local anaesthetic in the outpatient setting are well tolerated, efficacious and have minimal side effects. And in light of the shorter patient pathways that we experience as a trust for patients in whom we're offering that to, I think there are increasing gains to be made for both the trust and, obviously, most importantly, patients.